here with Jennifer Lowe. Jennifer, we're going to be talking about something very, very interesting. Let me tell you what we're not going to be talking about, okay? We're not going to be talking about the ASCRS clinical committee algorithm on OSD management before cataract surgery, except we kind of are, right? So one of the important things is MGD management. And in my practice, that's been sort of warm compresses and an atheist's prayer. And maybe fish oil and scaring people about doxycycline. But that's not how to manage it. And you're introducing it, it's new to me, a new way to manage it too. Just lay things out.
Okay, no, great questions. Right, as you know, we are aware now that almost 85% of dry eye is probably related to evaporative causes, MGD. Typically, the prior treatments have been warm compresses. That has been the gold standard for many years. But as of late, we know that there actually are better ways to treat the glands, including thermal pulsation and other heating modalities. And as you mentioned, there are newer devices coming out. I'm actually participating in a clinical trial for a new device called TearCare. And it's basically we're doing a multi-center, randomized, prospective, single-masked clinical trial comparing TearCare to LipiFlow, also another great device. And it's a non-inferiority study. I think that all these devices, though, have a great role in managing the ocular surface and have really been underutilized. So we have lots of great new technology, including micro blepharoexfoliation, such as BlephX, and then these warming devices. So we can actually go beyond at-home treatments to really target the therapy.
So I know from experience the dismal results that I get with encouraging patients to do warm compresses. Let's pretend that the patients are compliant and actually do it. Why do warm compresses not work?
We believe that the warm compresses are not able to sustain the correct amount of temperature you need, which is about 42 to 45 degrees Celsius, for a significant amount of time on the eyelid. You may only get a couple seconds of heat, really. So again, assuming that there's patient compliance, is really not targeting enough heat to the eyelids in an appropriate manner. And then we're also learning that there's an important part of the concept, which is expressing the glands, which of course a patient's not able to do at home.
Right, and had better not try.
Right.
So tell me, what does this new device, what's it called again?
TearCare.
What does the TearCare device look like? What does the LipiFlow device look like? How do they differ? What do they do? What's the length of treatment? All of that, that sort of stuff.
Great questions. And again, they're both great devices. I have them both. LipiFlow is a very automated device. You put these activators in the patient's eyes around their eyelids, and the device is completely self-directed, where the machine heats the glands and also does a pulsation treatment. So it's very simple, type set it and forget it type thing. The doctor immediately places the activators in, removes them at the end of the treatment. So very nice and comfortable for the patient.
The duration of a typical LipiFlow treatment?
It's 12 minutes.
12 minutes, okay.
Yep. Now, TearCare is similar concept, except it's actually these special warming lid devices that go external to the eyelid. They're placed on for 15 minutes, so a few minutes longer, and they also warm the lids externally. A nice thing about TearCare as well is the patient's able to open and close their eyes at will, and they
can see when he or she does.
They can see, yes. Yeah. I mean, they can even look at their cell phone, although we should really be discouraging that since we think that screen time is probably causing a lot of these issues, but they can look around, look at their cell phone, do things like that. And then after, you remove these smart lids, they're called smart lid devices, and then you use a special manual expressor developed by the company to actually massage and compress the lids.
At the slit lamp.
At the slit lamp. The physician does this, so it can be very customized and tailored to the patient's needs, because as we know, some glands are fine and some glands need more work.
So, and how long does expression take? I mean, I've done expression with meibomian gland forceps, which I assume these are these are similar, but I haven't done it with this sort of pre-warming. I don't
Pre-warming.
have this.
Yeah, the
device.
pre-warming helps. It's already sort of melting the mybone,
Yeah.
which is great. You can do the expression as long as you'd like. I mean, I usually make 2 passes around each lid. I like to take my time. I really like to get in there. So I think, but as time goes on, you'll probably become more efficient at
But
it.
still, we're talking like,
10
3,
minutes.
5 minutes.
Yeah.
Oh, really? Even,
well,
okay.
maybe I may be a little too long.
No,
maybe
that-
it seems like
that's-
10 minutes to me. But yeah, I think within 3 to 5 minutes would be reasonable as you get more efficient.
Okay, I'm not going to ask you prices because, but I mean, understanding this is the conversation that we have when we're planning things out for purchasing for the office. It's a conversation ultimately we have with the patient. Just tell me, are the consumables for these 2 technologies in the same ballpark?
They are. And the great thing now that we have at our fingertips is the price of the technology is coming down. So it's become much more affordable for our patients. I think that it can become a first-line treatment. I often will start the discussion by talking about warm compresses, get the ball rolling. Usually, as you mentioned, patients really aren't that enthused about doing that every night. I mean, we're all busy, right? And when I mention the price point, I've had many patients say, well, you know what, I'd rather pay that money instead of having to do the warm compress myself, saving the time.
So do you tell them subsequently that they don't have to do warm
Well, that's a good
compresses?
point. I actually still encourage them to do the warm compresses home. I really love the dental analogy that we often use. I say, look, this is like your once or twice a year dental cleaning.
That's a great
and then
way to
you
put
need to
it,
do your
yeah.
homework. You go home and you put your eye mask. I always tell them, they say, well, do I need to do this all the time? I'm like, well, do you brush your teeth every day? And they always look at me like, well, of course I do. Are you crazy?
Yeah.
I'm like, well, then you should be taking care of your eyelids. So when you put it in that frame, they suddenly realize how important it is and they accept it. So yeah, so I say do the treatment. This is a starting off point. We're getting your lids on the road to recovery. And then if you can, also do your homework and keep up with the heat. So
there are a zillion things that I could ask that I'm not going to, such as how does this play into pre-biometry for cataract surgery? That's a huge topic, and obviously this plays a very large role. Let me just ask one question for people like me who have a lot of MGD patients but don't have any of these technologies in his own practice yet. How do you have that conversation with a patient?
to begin with, prior to surgery?
We're
anything.
not even talking about surgery. It's an MGD patient whom you feel would benefit from the technology. How bad does the MGD have to be for that thought to run through your mind? And then how do you introduce this non-covered procedure to the patient?
Great question. So as I've been paying more attention, I found that, of course, it's more prevalent than I even realized. So if anyone's having any kind of symptom, I have all my patients fill out an OSDI when they walk in the door as part of their check-in process. And then I review it. I also, of course, ask their symptoms. If they have any kind of symptom, I, of course, examine them. And then I will start the discussion. I say, hey, even if they're mild, I again use a dental analogy. I say, if you hadn't brushed your teeth since the time you were young, you would probably have very bad gum and teeth hygiene, right? So even though you're young, even though you may have mild symptoms, it's so important to get this started. You want to keep your eyes and eyelids healthy your whole life. So I say, hey, this is an important thing to get started with. It's almost like a hygiene type thing that we should be doing, a preventive treatment. Again, maybe you consider doing it once a year if possible, and then doing your own routine at home. And again, this is prevention. Not only should we shouldn't be looking at it just as a cure, but really as a prevention. So that's how I start the discussion.
Because once gland tissue's lost, it's lost and it ain't coming back.
That's what we believe. So
Yeah.
we, just looking at the more elderly population, you see the meibomian gland dysfunction, you see the telangiectasias, you see the end stage, and it must have started from somewhere. So I believe that getting these patients young is better. And as you know, with all the increasing screen time, we're seeing younger and younger patients coming in with these complaints. So I start the conversation. I say, hey, even blinking more is helpful. I just get that thought in their mind. There's a 20-20-20 rule, 20 minutes of screen time, take a 20-second break, blink your eyes, look 20 feet away. I even try and remind myself I should be blinking. So I just get that discussion started and say, hey, this is a treatment that you should seriously consider. And again, it's not only for your benefit, but for your long-term future as well.
So how's the study going? The comparative? Do you have data yet?
Data's not yet released, but the study's going really well. We're currently enrolling patients, and we're trying to get to about 138 patients.
Oh, that's great. So
multi-center.
when am I going to have the next conversation with you that I can ask about sort of your preliminary
No,
findings?
great question. So we're hoping to release some early preliminary data in Q1 of next year. So probably by ASCRS.
Yeah,
we'll be
no,
able to
that's
speak about
we'll
it.
be in Boston. We
Yeah,
can
we'll
we can
connect
talk
again.
about it. Yeah, no, it sounds great. Jennifer, this is really, really, really great stuff. There are conditions that we used to be loath to diagnose because there was nothing that we could really do about
Correct.
it. So things come to mind: keratoconus, progressive myopia. I mean, these were things that we weren't eager to diagnose because we couldn't treat. MGD's in that basket too, because now we have these new therapies, and maybe it'll be something that ophthalmologists will be more interested in.
I completely agree, and I think it's really almost a public health service announcement that we really need to start making as part of eye awareness.
Absolutely. Jennifer, I want to thank you. This is a wonderful topic, an interesting
Thank
study.
you.
I'm on the edge of my seat, not literally because I would block the beautiful framing that the iWorld staff has done with these cameras. But I want to thank you for the generosity of your time with us today.
Thank you very much for having me.